So I'm talking about N-of-1, not referring to the number of Twitter followers I have or my current bank accounts, but really N-of-1 studies. I've been grappling with a few cases lately and how to approach them, rare disorders with expensive treatments. So I was reminded about N-of-1 studies, and I thought it might be handy to go back, review them, and try and understand perhaps why we're not using them more frequently. So evidence-based medicine is what we're all supposed to be practicing, and the principle is integration of objective data to inform clinical judgment. There is a slightly salacious approach to this where bigger is better, and the more patients you have, the better your data. It always starts with expert opinion, with difficult and rare conditions, and going all the way up to evidence-based guidelines, and somewhere in between there are case studies and randomized double-blind controlled trials. But there's a problem with our current approach. Many of the patients that we see are ineligible. There are lots of exclusion criteria, and certainly somebody who's got some experience here, getting clinical trials started in other populations in Africa and in third world countries is incredibly challenging. And trials generate an average treatment effect. That's really, really challenging when sitting in front of you is a patient who may have lots of comorbid conditions, you've got lots of genetic variables, cultural variables, environmental variables, and you're sitting in front of a patient and you're saying, well, this is the best possible drug for you. And we're basing that on the evidence that's available. And of course, trials take a long time. And with rare diseases, you never get to that critical mass. There was a paper a few years ago, which I saw and was reminded of from Nature, just looking at numbers needed to treat. And these are drugs that we often prescribe. But to achieve the outcome from those studies, numbers needed to treat is sometimes eye-watering, especially when you consider the cost of some of these drugs. If we look at rosuvastatin, massive numbers before you get the desired effect. Capexone, which was prescribed by many people in the group for many years, Cymbalta. So when you're sitting in front of a patient, you're telling them they're on the best medicine available that science can provide. Sometimes that's not what you see in front of you. And of course, that brings me to N-of-1 trials, which are experiments designed to determine the effects of an intervention on a single individual and increase your precision on that individual. So N-of-1 trials are when you take an individual and you have multiple pairs of treatments alternating with placebos, and this is double-blinded, randomized, and it's a crossover trial, but for an individual patient. And this really brings the best possible objective data, but to the individual. And if you start to unpack how you do these trials, there are certain criteria, but what you really want to do is that you design the trial, then have the patient enter into the trial with a randomized either two different therapies, you have a placebo in between, and at the end of that, you have an outcome for that individual patient. And of course, this is quite handy if you do it using standardized outcomes, because then you can compare that patient to patients around the world. But there are some requirements which make it challenging. So the patients firstly have to be compliant, there has to be capacity and obviously consent. We'll talk about ethics in a minute. And there needs to be a relatively stable condition, which can make it very challenging in some cases, because if there is a constant change within that individual, you're not sure if you're actually getting an outcome that's desirable or if you're actually measuring the disease. And the treatments need to be randomized. They need to work rapidly and have short washout periods so that you can measure it over a relatively narrow period of time. And there can't be obvious side effects. So if you try to do a study in entacapone, for example, the patient's urine turns bright orange every time, that's obviously going to introduce a bias into the study. And the outcomes need to be clinically relevant. And of course, if you're dealing with an individual, it's sometimes much easier to discuss it with the individual and have outcomes that are appropriate for that person. And there needs to be standardization if you want to publish this. And I think that as we're entering into the era of wearable devices, whether it's an EEG, whether it's a kinetic device, an EKG, that should make these trials a little bit easier. From 2015, there was the SENT guidelines on how to perform these trials. So what? And where to from here? I think that's always a good way to end a study, a talk, especially when talking about research. N-of-1 studies are really helpful when you're looking at very expensive therapies. And if we think about many of the patients that we see in clinics and have seen in clinics over the years, where you sit in front of a patient on 5 or 6 different drugs and just keep adding on drugs, or if you've got a patient on a very expensive drug and you're not sure if it's actually working in that individual, these studies become helpful. But there are disadvantages. If you want to do this regularly, for a clinician who's really busy to do this all the time, it's challenging. There are certain units that I'm aware of in the Netherlands and in the States where they actually have a dedicated pharmacist who helps with the blinding of the trial and randomization of the individual trial. You need a statistician. But what it does provide then is direct evidence for that patient. You have increased confidence, and so does your patient, that that's the best treatment for them, and it makes it precise. There's no financial support. We can't go to CRF and have lots of pharmaceutical input. But of course, if this increases the precision of medicine and the efficiency, ultimately this is going to reduce costs to a healthcare service. And of course, there's a time commitment. It takes a huge amount of time to actually sit down and design it. But of course, it also takes a lot of time to see the same patient over and over and over and keep adjusting medications over many years to try and improve that patient's outcome, whether it's epilepsy, whether it's inflammatory disease. Not always publishable, and if you want to publish, there has to be good standardized measurements for the patient. And of course, there's ethical ambiguity. So if you have a patient who you're not sure if the treatment's working, for example, a patient with botulinum toxin, you're not sure, doing it as an individual patient is not necessarily going to require an ethical approval. But of course, you may need an ethical approval to perform an unusual treatment in a rare disease. But of course, is it ethical to continue treating a patient without evidence that that's a treatment that's working for that patient? So just before I go, I think there's lots of opportunities just in neurology. There's a systematic review of N-of-1 trials in neurology quite recently, and I think it's an interesting read about some rare diseases.